We're very honored and pleased to have Niall Brennan join us to give the closing keynote address this afternoon. Niall is the Chief Data Officer and Director of the Office of Enterprise Data and Analytics at the Centers for Medicare and Medicaid Services. He oversees the data collection and dissemination at CMS to optimize the value of this huge data set to drive improved quality performance and foster patient-centered care at lower cost. So we'll all be interested in hearing how that's going. Niall directs the leading-edge data research and analysis published by CMS. Prior to joining CMS, Niall worked at the Brookings Institution, Medicare Payment Advisory Commission, the Congressional Budget Office, the Urban Institute, and PricewaterhouseCoopers. So he certainly brings a diverse background to this challenging position that he holds. Please join me in welcoming Niall as he provides our closing keynote address.
Good afternoon, everybody. Can folks hear me? Yeah? It's a pleasure to be here. This week, I acquired a rare and potentially life-threatening condition known as a man cold. So let me apologize in advance. I'm not entirely on top of my game. But if you don't enjoy the presentation, I can blame the cold. And if you do enjoy the presentation, you can wonder how much better it would have been if I was on the top of my game. I can't find a clicker. So I'm Chief Data Officer at CMS. We sit on a lot of data. We cover an awful lot of Americans, either directly or indirectly. We're the 800-pound gorilla in American healthcare through Medicare, Medicaid, and the health insurance marketplaces. We've obviously been deeply engaged for a number of years in trying to make the healthcare system a better, more efficient place. This is from the Secretary's Delivery System Reform platform. Everybody tends to focus on insurance coverage expansion, care delivery reform, payment incentives. I think the interesting thing here is, for me as a data person, is that information and the distribution of information and the harnessing of information was finally elevated to be a core platform of any delivery system reform area. And why is that important? It's important because and I didn't have the benefit of being at any of the other presentations, but I think most people can agree that our healthcare system has actually been a system of educated guesses for a very long time. And what we need to do is to turn it into an information industry to ensure that information flows from provider to provider, from provider to patient, from patient to caregiver, et cetera, et cetera, et cetera. So I'm going to go run through a couple of examples how we're doing this at CMS. They didn't just give me a fancy title. I think we're walking the walk as well as talking the talk. So I kind of divided it into a couple of different sections, loosely focused on, how do I get CMS data? So there are a couple of different ways to get CMS data. There's the publicly available data that anybody anywhere can get. And until about 5 years ago, that was pretty boring, not that useful data, but we've done a lot to amplify it and expand it. And I'm going to spend a few minutes talking about that. Then I'm going to talk about how researchers and smart folks at MIT can actually get access to granular level claims data to do really detailed research. So one of the things that we wanted to address pretty early on in my term at CMS was increasing the quality and the amount of data that we made available to the public. We had, a lot of kind of random data out there, kind of really, really high level. And so where we decided to really push was releasing more and more provider-level data. So this is information that didn't exist 3 or 4 years ago. It's granular information. It's big data in the sense that the Part D prescription drug file has 23 million records. So, it actually, you need to read that in and analyze it. So starting in May 2013, we released hospital charge data on every hospital in the United States for the top 100 most frequent discharges. That was dominated kind of the media cycle and the news cycle. Jon Stewart called it a miracle of competence in government. Following that, we released information, identifiable information on almost 1 million providers on how they practice medicine in Medicare. Followed that up with the aforementioned drug data. Followed that up with information on how physicians provide durable medical equipment. Followed that up with home health agency data, skilled nursing facility data, and most recently hospice data just a couple of weeks ago. So you can see we're covering, just about, most of the key touch points in the U.S. healthcare system. This is not de-identified. This is not anonymized. We have names, addresses, phone numbers on these data sets. And we now cover 85% of Medicare fee-for-service costs with these data sets. And you can all, probably download them right now while I'm talking. So I want to just give a couple of practical examples of how the things you can do to use it are the things that we found interesting. So skilled nursing facilities, we pay them according to a range of different criteria, but one of those criteria is the provision of therapy. And we noticed that for the top two most complex therapy groups, that there was a lot of geographic variation in the proportion of cases that fell within a 10-minute window immediately after the higher payment threshold. So to a certain extent, that's just providers behaving as rational economic actors. But to another extent, the variation, particularly the geographic variation, was a little troubling. So you can see in the South, more than 70% of these cases at skilled nursing facilities are falling within that 10-minute window. And for the slightly less complex therapy cases, the patterns are largely the same. So then you can dive down just looking at skilled nursing facilities in Boston, and you can see in the Boston area, and you can see that there's a range of facilities for whom some of them, 98, 99, 100% of their patients are falling in that 10-minute therapy threshold, and others it's more like 9, 12%, and everything in between. I think it's reasonable to question for a facility for whom so many of their patients are falling within that threshold, and it's something that our program integrity and fraud people are following up on. If so many of your patients are falling in that 10-minute threshold, it suggests that some people are either getting too much therapy, or some people are potentially not getting enough. You can look at it on pretty maps like that, et cetera, et cetera. So we've placed a huge emphasis on putting all this machine-readable data out there and having folks like you, data innovators, ingest it, combine it with data that we don't have in efforts to create new insights, new ways of engaging patients, new ways of piercing the veil of darkness that frankly envelops our healthcare system in many ways still. We don't have a lot of resources to do this, but we do also try and build slightly more consumer-friendly interfaces for folks who don't want to download a CSV file with 23 million lines of data. And so there are a couple of examples of that here, and again, you can find them on our website. So that's part one, public use files. Part two, how do you get to the good stuff? And apologies, there's some minor formatting problems with my slides, so I apologize for that. There are a number of ways you can get to granular claims level data. Joe, of course, and others are well skilled in the dark arts of acquiring CMS research files. So the first way is if you're a researcher. We've given data to researchers for many years under the HIPAA research provisions. The second way is as a qualified entity. It's an organization that was established, a class of organization that was established under the Affordable Care Act, and I'll talk a little bit more about that. And then also as a state Medicaid agency, or as a provider organization who's engaged in trying to improve care or reform care or transform care with us, and we've got a couple of examples of that. So the one word you really need to know for any researcher anywhere in the country who wants to get CMS data, you don't need to know my name, you need to know RESDAC. RESDAC is the Research Data Assistance Center. They're these delightful Midwesterners based in Minnesota. They're way more polite than me. And they are there to help navigate people through the, at times, seemingly Byzantine way of getting CMS data. The engine for all of our public use file releases, all of our research releases, and all of our internal analytics that I'm going to turn to a little bit later is the very sexily named chronic condition warehouse. So this is like an absolute joy of a data warehouse. It's built by data users for data users. We've got absolutely tons and tons of data in there. Medicare data going back to 1990, linked across time, across setting, across Medicare and Medicaid where appropriate. We've got assessment data, we've got denominator data, we're ingesting Medicare Advantage and counter data. And interestingly, for folks in this room too, traditionally we had restricted access to Medicare data to tweed jacketed academics like Joe, who is very kindly actually wearing a tweed jacket, so I can prove my point today. But like, you know, professors doing academic nonprofit research, we changed our policies about a year and a half ago, allowing for-profit companies or people with a for-profit motive to virtually access CMS data through our virtual research data center, because HIPAA actually doesn't distinguish between academic research and for-profit research, you know. And, you know, the reason we did that is, one, and this is a terrible thing to say on such sacred ground as MIT, but academics don't necessarily have a monopoly on innovation and good ideas and how to identify cost-saving ideas in healthcare. And two, we had launched the Virtual Research Data Center, and that gave us the technological platform and security where instead of physically giving data to researchers, which is what we've done for many years, we could grant them virtual access to data and keep a slightly closer eye on what they were doing, because, you know, there's a slightly higher threshold of wanting to know what's going on. So we have about, I think, 15 to 20 what we call innovator researchers in the VRDC now. And so you can go in there, you access the granular data, you do all your analysis, you build your predictive analytics or algorithms, and then you can take out aggregated data, and we screen it just to make sure that no PII is leaving the environment. So we're very happy with that. Qualified entities, I think they emerged out of the Affordable Care Act and the conceptual framework for why they emerged. And I know Dana was here earlier. I don't know if she's still here now, but you know, 5-10 years ago, what was happening in the provider community is that providers were receiving one report from Aetna, one report from United, one report from Cigna, and nothing at all from Medicare. The reports looked different, used different methodologies, came to different conclusions about the same quality measures, and providers hated them with a passion. They sued and won in many states over, you know, over these reports being unfair or arbitrary or not impartial. So what the QE program does is it creates a framework where CMS gives qualified entities 100% extracts of hospital, physician, and drug data, as long as the qualified entity can prove to us that they have enough claims data from other insurance companies that when combined with the Medicare data, physicians can actually get comprehensive reports that cover all or most of their practice. There's, you know, more criteria than just having claims data from other issuers, but it's the most important criteria. So, and you can see the magical effect that the qualified program has on the receiving physician getting the report. So under MACRA, while that was mainly about MIPS and the quality payment program that we launched last week, there were a number of other important provisions in the rule. One of those provisions was granting more flexibility to approved qualified entities in how they use and reuse the data. There was a very strict statutory interpretation originally that they could only use the data they received from CMS for the creation of public performance reports. Well, we all know that, you know, the true business of quality improvement, while transparency and public reporting is a very important component of that, equally, if not more important components are working directly with providers, getting them the information they need, getting them, you know, multi-layered secondary type analyses to help them improve. So QEs have now been granted considerable flexibility to use and reuse CMS data, particularly when it's combined again with the other data that they have. There's also an opportunity for clinical data registries to obtain Medicare data. So, and then finally on the accessing kind of granular CMS claims data. We are sending real-time monthly data feeds to folks participating in APMs, ACO programs in particular, the comprehensive primary care demo, and we also partner with a lot of state Medicaid programs on giving them matched data for their Medicare and Medicaid populations. I think state Medicaid programs are actually an interesting test case. You know, one of the things that I face is that everybody that I come across wants all CMS data for free to do whatever they want with, and I have to kind of gently walk them back from those expectations. You can't have it all. You're probably going to have to pay for it, and you know there are going to be restrictions on your use. So you would think that state Medicaid agencies, you know, they are a key and valued partner for CMS, right? But the only data that they sort of have a legal right to is Medicare data for people who are also enrolled in Medicaid. So we can and we do give that to them. But if they want Medicare data for Medicare enrollees in their state, we basically have to say, get in line with the researchers, because I need a legal authority or a legal permission to give anybody that data. So I guess the third way in which people can get data, and this is getting just a little forward-looking and a little futuristic, is Medicare Blue Button. Have people heard of Blue Button by any chance? Show of hands? Handful of hands. Okay, great. That ranges from everybody in the room raises their hand to a couple of weeks ago, nobody raised their hand. So Medicare Blue Button is a way for Medicare beneficiaries to download a machine-readable version of 3 years of their healthcare claims history for them to sort of use in whatever way they want. So again, think about as people navigate healthcare right now, trying to get basic information about themselves, it can be startlingly difficult. And it doesn't matter if you're a Medicaid recipient or a MIT professor, or if you're the son of the Vice President of the United States. If anybody has heard Vice President Biden speaking recently about the death of his son, one of the biggest frustrations and roadblocks that they encountered was getting access to the medical information about his treatments. So let me figure out what's going on here. So Blue Button actually exists at CMS, but it exists in a kind of a clunky, kludgy way. Beneficiaries, when they do the file download, it's an ASCII text file, and then you're kind of left, shrugging your shoulders. Well, what am I going to do with an ASCII text file? Print it out and cart it around to my providers. So we're rebuilding the entire Blue Button infrastructure to adhere to a standard known as FHIR, Fast Healthcare Interoperable Resources, but also to build an API framework so when beneficiaries come in, they can direct or authorize specific recipients, be they providers or healthcare apps or the like, to receive a regular stream of their healthcare claims data. I think this. And this is kind of a little picture that magically makes all that happen. But again, think about it. Everything from the little things like getting information on your kids' vaccinations can be, just embarrassingly stuck in the 1970s and involve faxes and letters and $25 fees and different things like that. But it's not just about the data that we have. How can you build an infrastructure that takes that data and combines it with the clinical data in your physician's EMR? How do you take that data and combine it with your wearable data, with the data on your Runkeeper or your Strava? I think when this becomes a reality, and it's when, not if, it truly has the potential to be transformative in terms of how people view their health and how people use data to navigate their health and healthcare. So how am I doing for time? Oh, 12 minutes, there it is. I wonder where the clock was. So I'm going to turn to a couple of stats now, and again, apologize for the formatting issue. So we don't just push data out. I have a team of about 25 to 35 data scientists, programmers in-house at CMS who are constantly in the data, looking for new trends, exploring exploring hypotheses, et cetera, et cetera. We were the first ones to track the dip in readmission rates starting in 2011, 2012. So you can see the secular decline followed by a leveling off. We can drill up or down as much as we want down to the individual hospital level, and we frequently do that. So here are the rate. So this goes through June 2016. The national map we have through 2015, and then you can analyze change at any geographic level, or again at an individual hospital level between 2011 and 2015. So the map is almost all blue. That's a good thing. Readmissions have gone down just about everywhere. There are pockets of yellow, and then as healthcare planners and healthcare leaders, you can figure, start to ask questions why certain areas are yellow. Yellow, doesn't necessarily mean bad. It just means, the rate went up, and, how do we understand why the rate went up? We just published a paper and released a data set on hospice spending over the last 10 years. So hospice was originally intended as a benefit mainly for cancer patients that wouldn't cost a lot of money. Costs have absolutely skyrocketed in recent years. They leveled out in the last 2 years and then took a tick up again in 2015. So these charts show that. I think, interestingly, and again, I'll have to walk you through these slides, but this is a classic example of how providers respond to CMS payment incentives. So you see the kind of, well, let's call it a purple line, the one that's skyrocketing up by 296%, and the red line that plateaus down to 0. So the red line is a clinical condition, let's call it debility. And so 2 years ago, we were like, you know what? Debility is not an appropriate disease classification for hospice care, so we're not going to pay for it anymore. And people said, all right, we're going to code everything as stroke. So, or at least that seems what they did, because debility went to 0 and stroke increased by 296%. So if you want a better example of the, we call it the balloon phenomenon in healthcare, where you push in the balloon and it comes out somewhere else, this is probably a good example. So you can see that in Boston, in the Boston area, stroke diagnoses increased by almost 300% versus 267% nationwide. Interestingly, though, Boston was operating from a lower base. Well done, Boston. So the percent of overall hospice beneficiaries with a primary diagnosis of stroke is only 6% in Boston versus 8% nationwide. So, and then you can see that cancer diagnoses have declined to where they are less than 30% of hospice cases nationwide. And so, again, these have lots of kind of intersecting effects, because there are more and more people now, I want to choose my words very carefully here. There are more and more people leaving hospice care alive, which is a good thing, but it's not necessarily what hospice care was intended for. It was originally intended as palliative care. So I think that's it. We have 8 minutes left. I'm happy to answer questions, and we already have one in the front row.
Thanks. Great work on the Medicare area, but I deal with Medicaid. And the tool I had 5 years ago was called MSIS. Since then, it's said the site will come back up in November of 2014. When do we get some Medicaid data back?
So it's a... Joe, do you want to tell him? It's a great question. The Medicaid folks, so Medicaid's different, right? I live predominantly in a Medicare marketplace world, even though I do have some responsibility for Medicaid too. But if a doctor doesn't give us data under Medicare, they don't get paid. And it's one program, whereas Medicaid, it's 50 state programs. And so if states don't give us Medicaid data, they still basically get paid through the matching grants and different things like that. So the incentive structure is totally different, right? It's a lot harder to get Medicaid data. And the Medicaid data that we have tends to be dated and of poor quality. That being said, the folks on the Medicaid side of the house at CMS are working hard on TMSIS, with the T stands for transformed. And they have, I believe, they're collecting data now from about 7 states. And I think the goal is to have data from all 50 states maybe sometime next year, and then ideally start making it available to people shortly thereafter.
Why not at least give us back the old tool?
I can certainly give people that feedback. So, are you talking about the cubes?
MSIS.
Yeah, the little analytic cubes. Yeah. So, I think that was a trade-off kind of thing where they needed to pay for the new data collection thing, and I'm not saying it's excusable or ideal, but that's what happened. Question here.
Thanks. That was a great talk, and I'd love to be able to see and have access to this kind of data. It's fantastic. The hospice stuff is really interesting to me because I'm an intensive care physician, and it has moved from cancer to other things.
Yeah.
I think because we are creating very complex patients in an ICU setting.
Yeah.
That may survive or may not.
Yeah.
And it's better that they go to hospice than they stay in an ICU and you're being billed and paying
Yeah.
for ICU care. And if we think they need to go, we're going to find the right code to get them there.
Hence stroke.
Hence stroke. And I think it's important to look at this in relationship to ICU rather than just a standalone hospice.
Yeah. No, it's a great comment, and with a lot of these talks, like you can, or examples, you can kind of run a fine line because we are looking at things in isolation. I'm not implying that the decline in, cancer-related hospice admissions is a bad thing, but I do think it helps us as a learning healthcare system to understand, that it's happening and where it might be happening more than other places. So, thank you.
The data is based, a lot of your data is based on ICD codes, and the physicians are not particularly interested in spending much time finding the right code, and they'll find something that works for them. Can you comment on the quality of the data you get when you actually go into the office to see what the code should have been according to you, and what the physicians, and does that matter?
Well, I mean, that falls into the category of things that, like, I could stay up at night, lying awake, wondering about, but sort of choose not to. I mean, I think there's all kinds of studies that have looked at chart abstraction that range from administrative data is pretty close to what's in the chart to administrative data is not close at all to what's in the chart. So, and, I sort of don't know, which study you should place more weight on. This data, the thing about administrative claims data is, that stands out for me is its universality, right? Yes, we have clinical data. No, it's not stitched together or standardized in any kind of way that makes the kind of large-scale research and analysis and dissemination that's possible with claims data today. So, is it perfect? No. Can I imagine a world where we didn't rely on this data and researchers didn't rely on this data for insight? I can't imagine that either. Front row or second row.
Yes, I just want to have a question about the API call to get to the data that you're going to make available for health apps.
Mm-hmm.
When do you perceive this is going to be in function, even if it's a data mode?
Probably mid next year.
Okay.
Yeah. We've built out the back-end FHIR platform, and we're loading it now with, I think, about 9 billion records. And then and then we have to, we're also working on the front end, but we need to actually get all the pieces in place. So the front end talks to the back end.
Get a specific patient's information.
Yeah, the only way you get it is if the patient authorizes it.
Okay.
Yeah.
Okay.
Yeah. Okay, there's 2 minutes for more questions if you guys want. I love this microphone.
Yeah, sorry. Thank you. So I just wanted to comment that I noticed that you put up 2 policy changes. One resulted in affordable, the readmissions, reduction in readmissions, and the other one might even be like a data cleaning kind of policy change in the end, because the term that was used didn't make sense.
Oh, you're talking about the hospice versus the readmissions, yeah.
Yes, yeah. So I thought it was interesting to just note that these are policy changes, and we haven't really talked a lot about policy changes that could help our healthcare system. And I'm wondering, do you think at all about, or what can we think about policy changes to have them actually have the effect rather than just an artifact?
Well, so, I mean, that's kind of the million-dollar question in healthcare that people have been struggling with for years, you know? I mean, even the decline in readmissions is not the effect of a policy change. It's the effect of about 28 different policy changes. Readmission penalties, technical assistance to help providers do better post-operative care management, ACOs, sentinel effect, you know. I actually don't know what caused the decline. I just know that it happened. You know, observation stays, even though we proved that it was not driven by an increase in observation stays empirically. So, you know, I think all policymakers or folks hoping to influence policymakers have, you know, the best intentions at heart. So, but whether it actually translates into something tangible is always in question.
And sort of a technical follow-up question. The data that's becoming now available, I think you said it was in CSV format?
Is what?
CSV format?
Yes.
Have you considered it all for interoperability RDF?
I don't know what RDF is. Maybe that disqualifies me to be a chief data officer, but I'm happy to make it available in RDF if it's not a huge lift. So.
Okay, I'll remember that.
Okay.
Hold you to it. Oh, thank you.
We got a question at the back.
Yeah, one last question.
Yeah.
I come from working with Medicare Advantage plans. Is it still, did I hear you correctly, that most of these data sets still don't include Medicare Advantage, and why is that, if that's the case?
So Joe's laughing at me down here at the front because you know, we had a bet over how long it would take for a Medicaid question and how long it would take for a Medicare Advantage question. So we got one at the very start and one at the very end. So it's nice bookends. Historically, we did not require Medicare Advantage organizations to submit detailed claims information to us. That policy was changed starting in 2013, so we've been receiving it for a couple of years. My team is working closely with the operational folks who are collecting that data, and it's taken a little bit longer than I would have liked. I'd actually originally hoped to be able to grandly announce the availability of encounter data mid-2016. I've had to revise that to mid-2017, and I may have to, you know, eat crow on it again, but we actually are getting quite close. And then I think there's going to be a shakeout period of a couple of years, like the files. It's catch-22. I don't want to put out total garbage, but I don't want to wait so long until it's perfect. So it's going to be some kind of middle ground. We're going to put out files with very clear warnings, like, you know, don't use it for this, don't use these fields for that, this stuff is missing. And just doing all that, you know, while we're pushing out Medicare files and doing our own analytics, it's just a question of finding the time and the priorities. But we are working on it, and we know that researchers are salivating. So.
Thank you.
All right, I think we're set. Thank you all very much. Yeah.
All right, thanks so much. Right, so Niall pointed out the stereotype of my tweed jacket. The other stereotype is an absent-minded professor. I'm going to try not to be absent-minded and thank the right people. First would be Niall. I thought that was just a fantastic presentation, but more importantly, all the work that he does with pushing out data is the lifeblood of MIT, it's lifeblood of health economics. And if you I talk to providers, payers, data experts on the private sector, government agencies, My colleagues in engineering and economics that look at networks, they like to graph out networks and have powerful nodes or the most influential person. I would say Niall is probably at the center node of the health economics or health data research community and private sector users. So thanks very much for Niall for being here. Let's give him another round of applause. I think that'd be great. All right, second up, RedCef and I would like to thank, there's a lot of work that goes into these types of conferences. So Anna Quadras did a lot of work for it. Dave Weber, Donna Russell, and Jay Levine did a fantastic job organizing today. So I'd like to, and the staff that was helping us out today. Thanks so much. All right, I have one announcement. So there's a reception in the hallway behind us after this is over. And then those who signed up for the applied learning, that will take place at 3:45 in the building across the way, E62 in the first floor. There'll be a convening of those people in the lobby here at 3:30 to walk you over, just so you don't get lost. And then the last thing I wanted to do was just thank the audience. So thank you so much for coming. I know that you've really enriched the breakout sessions and the panel discussions. So thank you very much for being here. Have a nice day, guys.